Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This marks the second episode of a new mini-series, Psoriasis and Skin of Color Unplugged, supported by an educational grant from Janssen Scientific Affairs. Thank you for joining us for this second episode featuring our host, Dr. Mona Shahriari, and her guest, Dr. George Hahn, as they discuss gaps in diagnosis and dermatologist training.
Hello, and thank you for tuning into Psoriasis and Skin of Color Unplugged. I'm your host, Dr. Mona Shahriari. I'm an assistant clinical professor of dermatology at Yale University and the associate director of clinical trials at CCD Research. And today I'm joined by my friend and colleague, Dr. George Hahn. Dr. Hahn, why don't you introduce yourself?
Hi, thanks for having me today. My name is George Hahn. I'm on faculty, associate professor at Northwell Health, where I direct clinical trials, and pleased to be with you to talk about this fun and exciting topic today.
Well, thank you so much for joining us, because today we're really going to focus on those gaps in diagnosis and training when it comes to psoriasis and skin of color. So I know both of us, we see a lot of patients with psoriasis, but in particular those with a variety of skin tones. And it can sometimes be challenging to diagnose psoriasis and skin of color, and sometimes we might be left with misdiagnoses. So why don't you just kick us off by telling us where these challenges are coming from?
Yeah, I think that's a great point, because when you think about our training armamentarium, where depending on where you trained, your population may be very different, we get this classic picture of our skin diseases in our minds, especially when you think about psoriasis, that classical description of erythematous scaly plaques, micaceous scale. Those are concepts that mainly come from a more shall we say, light background of skin color. So when you deal with patients with darker skin tones, with more melanin-rich skin, you end up having situations that are a little harder to define, right? The scale may not be the same texture. The erythema may look very different. We often talk about violaceous erythema, but in some cases it looks violaceous to even brown. Like there's very deep darker colors that are a bit harder to define that you often see in our patients with skin of color. And so the differential actually ends up being broader. And I think part of that is from training, but part of it is actually just the natural tone of the skin. There is more diagnostic dilemma when you look at these darker toned patients where you're thinking diagnoses like, I don't want to miss mycosis fungoides. And so that really complicates things, not just maybe unfamiliarity with seeing a lot of patients with psoriasis and darker skin tones, but also just like we don't want to miss anything else.
Absolutely. And I know in my clinical practice, I tend to biopsy these patients a lot more. How about in your practice?
Yeah, we end up having to, because then you start to think about lichen planus, you start to think about these crossovers where even things like nummular eczema are a bit harder to define there. There's a lot of interesting work coming out recently around this so-called eczematous psoriasis, or psoriasis with eczematous features. And, I think there's a couple of different interesting avenues that you could go down here, because I certainly have some patients who have classic features of psoriasis and classic features of atopic dermatitis. Sometimes we have to put people on dual biologics targeting both sides. Sometimes we push too hard one way, it actually makes the other flare. So I've had some patients where we treat the psoriasis and then their eczema starts flaring more. So I think those are challenges. But then you get these other situations where there does seem to be this crossover. There were some interesting articles that came out recently pointed to maybe even pathophysiologically the role of IL-17C as a potentiator of inflammation in both eczema and psoriasis. So there are some kind of crossovers between these two cases. And then you think about, I mentioned earlier, lichen planus, lichenoid dermatoses. You think about mycosis fungoides, which we talked about already. There really are a lot more things to think about. So I think the inclination to biopsy is not necessarily a bad one. It's a natural one in a lot of cases. We often, by the way, in these patients, start to look for other clues, right? We're going to do more careful examination of their nails, really dig through the scalp, try to find clues of any other diagnoses, look in the mouth, right, to try to think about lichen planus again. So that really requires us, I think, to be more astute clinicians. And then, of course, we have the biopsy as our fallback option. But it has been shown that biopsy rates, we're not alone here, biopsy rates in skin of color for psoriasis specifically are much higher, on the order of 4-fold higher than in lighter toned skin patients.
And I think from just a treatment standpoint, it's so important to know what it is we're treating because nowadays we're privileged to have all these targeted therapies. But if you don't know exactly what you're treating, you can't give that best therapy. And I really think you hit the nail on the head there. Not only do we need to broaden the color palette when we're looking at patients with melanin-rich skin, but also broaden our differential diagnosis and not have premature closure to think it's one thing because, as you eloquently mentioned, there are so many other diagnoses that are on the table when we're dealing with individuals with melanin-rich skin. And I loved your comment about being a clinician because sometimes we have tunnel vision and just look at the skin, but looking at the patient as a whole can give us clues and insights into what the diagnosis is.
Yeah, I
Now,
think that's really important because especially when you think about the fact that maybe we're not sure, so we go to a biopsy, but the biopsy doesn't always save you, right? When you think about it, especially, it has been actually shown in, for example, Asian skin, that when you biopsy psoriasis, the reedy ridges are a little different from that which you see normally. There are other features like spongiosis that you might see that are more in line with eczema. So, it's not even like you can always get a slam dunk from the dermatopathologist to save us in this case.
I love it when they say cannot rule out eczema, psoriasis, lichen planus, but that's everything I gave you. Now what am I supposed to do? But I know for those of us who see a lot of Skin of Color, we are more well versed in really diagnosing and evaluating these patients. But a lot of our Skin of Color patients, due to social determinants of health, not having access to a specialist, they may not see a dermatologist. And even if they do see a dermatologist, sometimes that derm is not experienced in treating Skin of Color. And where do you think those gaps in knowledge, training, all of that come from?
I think it's a challenging question to kind of dissect out. I mean, there's just so much built into our societal fabric, the way our healthcare system is set up. And it's interesting because when you look at some of these studies, like the biopsy study we were talking about earlier, when you control for other factors such as type of healthcare insurance, those features actually persist. So I don't think it's a simple fact that, some people just have poor access to care. And so they're getting biopsied. They're getting stuck with people who don't really know what they're looking at. I think it goes deeper than that. And it's really that on one hand, you have the patients coming in with a broader differential diagnosis where it's tougher to tell. But on the other hand, I think these patients also tend to wait a bit longer until they come in. That actually has been shown also. So patients with skin of color and psoriasis tend to wait longer for the diagnosis, tend to be more undertreated when it comes to systemic therapies. So there's a lot that ties into it. I think we could do better in that we could be able to perhaps think about technology as a tool to interface with patients more easily, because I always get frustrated when you think about all those advertisements you see on TV all the time for psoriasis. The end of the commercial is always a call to action: talk to your dermatologist today. And you have people sitting out there in rural areas who are like, well, I don't have a dermatologist, I can't find one. And then they wait up to a year. We actually worked with a hospital upstate New York that the waiting time for a new visit for dermatology was actually a year. So you wait a year. I mean, first of all, you have no idea what you're doing in a year, right? So hopefully you remember you have the appointment, you're able to go there. But if not, you enter the queue again. So then you go there and then you actually end up seeing a provider who maybe has not really had experience giving biologics for psoriasis. This was actually the situation that we were faced with. And we were starting a teledermatology platform where we were getting referrals from the community to start patients on biologics for really severe psoriasis. Now, I can tell you, the most severe psoriasis I've ever seen were from this clinic and I asked the patients, they said they just gave up, right? I waited a year, I went to see somebody, and I just kept getting topicals that really were not cutting it. So I think there's a lot that we could make progress on, but the gaps are many.
Well, I think you hit the nail on the head there, the giving up mentality. Because if you're waiting that long and maybe you make it finally to that dermatologist and all they're giving you are creams, you lose hope. And sometimes you think, you know what, this is probably the best it's going to be. I'm going to have to learn how to live with this. And I think the reason we do what we do is to make meaningful changes, not only to people's skin, but also their lives. So there's a lot that we can certainly do and continue to work on as clinicians. Now, you did mention the public images, advertising campaigns. I know historically we've had a lot of fair skinned Caucasian patients represented in those. And even if you Google psoriasis, you have to scroll pretty low down on that first page of Google to get to a skin of color image. How do you think that impacts the treatment seeking behavior for some of our patients?
There's undoubtedly a big impact there, because if you go and look for pictures of skin conditions, which everybody does nowadays, right? They go to Dr. Google first, and you don't see people look at like you're kind of stuck. You have no idea what's going on. There was actually a mother who started a social media campaign because her child had a skin disease, and she went online and was stunned to see that there were no pictures that looked like her child. And so that's really impactful. I think it touches people on a lot of fronts. You think about even in our textbooks, right? The materials that we have for learning dermatology, there's a huge gap there when you think about the percentage of pictures. It's been cited as somewhere around 4 to 20%. I can tell you most textbooks are on the lower end of that. And there actually has not been much progress in the last 20 years for most of the resources. So even the pictures that we as medical professionals are getting trained on, there's a huge gap there. We're making some progress. The AAD has started a Skin of Color curriculum, which is excellent. And I totally think that everybody should take a look at that. But you think about the images, and I think we talked about this before, there is kind of a racial bias built into photography even. You think about our medical images, but even photography itself, when film was developed initially, we're talking like Kodachrome's early film, and this is 50 plus years ago, it was actually optimized towards lighter colored skin. There was this famous, Kodak released this famous picture as a calibration picture. It was called the Shirley card. And that was what all the people were trained to calibrate their cameras to, and the film developing, even the chemicals used for film developing. And so it was really optimized for light colored skin. So what you noticed is that for darker skin tones, you ended up with an ashy complexion, and then your teeth looked really white and your eyes looked really white, and it was totally out of whack and really made you look like something different from what you were. And it's interesting because it wasn't people saying that we need to fix color photography for this reason. It was, I think, in the 1970s or 80s when the two industries, the chocolate industry and the commercial furniture industry, went to the film developers and said, when I print my ads for my products, people can't tell between the shades of brown, so you have to fix this somehow. And that's why we started to get more diversity in our color imagery. So it's really interesting when you think about all of these unknown and unrecognized biases that we carry with us.
Well, and that can certainly influence, I think, that patient experience as a whole. But that was a very interesting tidbit that I didn't know about. So, of course, leave it to the industries that are making some money and have the big dollars to help improve, quote unquote, diversity in our images. And I know there's been, like you said, a lot of movements to help improve images. And I know both of us have an archive of skin of color images across various inflammatory disease states. But I know recently the Visible Skin of Color study, that really brought forth some novel techniques in terms of us not only diagnosing and treating plaque psoriasis, but also helping improve the number of images that we have. Can you comment on that?
So the Visible trial is really groundbreaking when you think about a really designed trial for Skin of Color. And I think they made a lot of smart decisions when designing this trial. They didn't specifically only look at Fitzpatrick types, because if you remember, Fitzpatrick really is well attuned to telling about burning, about maybe phototherapy responses, but especially when you look at types 5 and 6, I mean, that essentially is just slapped on as dark and really dark, and it doesn't really tell us a lot about skin tones and what kind of skin we're dealing with. So they integrated colorimetry, which is an objective measure of both being able to tell melanin content, but also erythema, really discerning between red erythema, violaceous erythema, picking out that red tone there. And I think the learnings from this trial will help us in a lot of ways going forward, because it'll give us better tools to really determine severity of psoriasis in some of our patients. Because when you think about it, a lot of us have been using guselkumab in a very diverse range of patients, and we know it works. So that really wasn't the fundamental point of this trial. The point of this trial is really to understand psoriasis better in these skin of color populations. And what's really exciting is that there's going to be a lot of biomarker data coming out. When you think about some of the some of the experiments have been done so far. We have seen in recent years a couple of interesting studies that look at the genomic kind of predisposition towards inflammation that African American skin has as opposed to Caucasian skin. It actually has been shown that the baseline inflammatory state is elevated in African American skin. Some of the genes that are upregulated even at baseline involve the TNF alpha pathway, for example. And the differential response to something like clobetasol is actually different. There are more differentially expressed genes that are up and down regulated as compared to Caucasian skin and African American skin. So this concept that everybody responds the same to all our medicines is certainly not true. But out of this, I think we're going to be getting enough nuance to be able to help discern out, for my patient in front of me who has really severe scalp psoriasis, for example, maybe their skin isn't so bad. Is there, better guidance I can give them, thinking about either therapeutics or guidance about how long it's going to take to get better? Those are things that we currently don't have the ability to do because our clinical trials for psoriasis drugs are vast majority Caucasians, white Caucasians. And you think about it, even I think our epidemiologic data looking at prevalence of psoriasis, which generally shows that psoriasis is highest in prevalence in the white Caucasian population, there's almost certainly a lot of error in there looking at diagnoses, looking at reporting. So I think that's stuff that having this image database out there, really calling patients in, calling more attention to this is going to help with in the long run.
And I think the 20,000 plus images that they are generating from this study is really going to be the legacy that we're going to use as not only healthcare practitioners, but medical students, residents in those early stages of training. Because if we can get people at that stage, then they can build upon that knowledge and really will be armed for the patients of the future who are going to have a variety of skin tones. I do know they used the cross-polarized photography in this study. How do you think that also helped in some of the assessments? And do you think there's a role for that in day-to-day clinical practice?
Yeah, that's pretty cool because when you think about cross-polarized light, it helps kind of get rid of the surface reflections that you may see from the scale, for example. So it's quite striking that you can discern the erythema a lot better in these patients with a simple cross-polarized light. And it sounds kind of fancy, but I'll just remind that we almost all have one of those in our pockets nowadays because that's what your dermatoscope is. The non-contact dermoscopy is cross-polarized light. So if you're kind of unsure about it, you're trying to see how active the disease state is, that's a helpful tool because it helps you see the erythema a little bit better. And that's something that you can, take home tomorrow and start using.
It's interesting because our dermatoscope is such a tiny device and we focus more on let's look at skin lesions, let's diagnose skin cancer. But I use it a lot for my patients with skin of color, even if I'm trying to assess induration of a plaque, use a little bit of side lighting. Like you said, the cross-polarized function. So that little tool does a whole lot more than I think a lot of us realize. And then just to kind of bring this home for our audiences and our listeners, we talked a lot about the gaps in medical education, why it's important for us to be able to diagnose skin of color, plaque psoriasis early and appropriately treat it. But why do you think this is such an important issue currently versus, say, 20 years ago? Because there's a lot of emphasis on it nowadays.
Yeah, I mean, there certainly is in our society a trend towards being more inclusive and just understanding people of different backgrounds, which is a good thing, undoubtedly. But behind all that is the simple fact that the racial makeup of this country is changing such that the white Caucasian majority will no longer be so in probably the next 20 to 30 years. So it's important that we really understand that our clinical trials are designed to be very rigid in some ways on purpose, right? Because we want to make sure safety looks good. We want to make sure that we understand what we're getting into when we prescribe certain medications. But the voice of the people saying, we need to do this for everybody who's affected by this skin condition or any other disease state, you could say, is starting to rise up more. And you think about a lot of the built-in biases in our societal system, but also when you look at how it affects health, looking at essential hypertension, for example, and the different predilection of different racial groups for that. I mean, these are things that we need to put more focus on because the tools and solutions for everybody might not be the same. But on top of that, I think the counseling, the understanding of baseline, maybe inflammatory predilection. So you think about risk, for example, of people developing psoriatic arthritis. And that's another thing that over the longer duration of this trial, we'll start to see coming out. Thinking about that is really important as well. So looking at our disease states as a whole, not just in a box, is important. We know, of course, with psoriasis, there's a large predisposition towards metabolic syndrome. Our patients with psoriasis are at higher risk of adverse cardiovascular outcomes. So there's a lot, I think, that needs to be studied on this matter. And there's a lot in that, not just simple treatment response, but in comorbidities, in other aspects of patients' health that we need to understand through the lens of diversity.
Well, and I think one thing the Visible study really was bringing home was that patient journey. These patients with plaque psoriasis have skin of color. What are the unique considerations that we need to keep in mind when we treat them? Like you said, there are so many nuances that go into play that apply to those patients, like post-inflammatory pigment alteration. Both of us have skin of color. Both of us know that our skin pigments a little differently than the average Caucasian patient. And I think that was another piece that this study was able to really bring to light. Do you think that any of the tools we have currently in our armamentarium will help us better diagnose post-inflammatory changes so that we don't underdiagnose the plaque psoriasis?
PIH is important to our patients, no doubt. Because you think about it, I always think when you do the DLQI or you do some of the patient-reported outcomes, one of the important things that we ask is, how is your skin disease affecting your day-to-day activities, but also the clothing you wear? So if we kind of fix their psoriasis on their extremities and we're so happy because their elevated erythematous plaques are down, but they leave this brown stain essentially for, in some cases, years, that patient's still not able to wear shorts or short sleeves comfortably. And so we haven't really fixed their quality of life in as meaningful of a way. And so that's often like, you see these patients and you're like, well, this is so great. You see them 3-4 months after your psoriasis is gone and they're saying, but I don't feel better because I still have these marks on my skin, and I don't care if they're red or brown, they still really bother me. So I think what's interesting here is that we don't understand PIH well at all from a pathophysiologic standpoint. We don't really know why it happens. So hopefully we'll get some better data out of that. But more than that, I don't have a good way of predicting which of my patients is going to get really bad PIH, because it's not always intuitive, right? You think maybe darker skin tones, there's more melanin content. You can dump more of the melanin with any kind of inflammation, so you get worse PIH. That really isn't the case. I've had what you would call very dark Fitzpatrick phototypes, who you kind of get the psoriasis under control, and 4 months later, you couldn't tell they had anything on their skin before. Whereas with a patient with a more moderate skin tone, who you would normally put into maybe Fitzpatrick 3 or 4, they're going to have that really bad PIH that lasts for much longer. And I think part of that is probably because of the contrast there, but also there's some mechanisms that we just don't understand about this. So I think having a better way to delineate that is going to be important, not just in psoriasis, because in psoriasis, if anything, it's a call to action to say, let's not undertreat, because we know two things, right? The skin of color patients are undertreated, they wait longer, and so they're probably going to get more PIH. So we should fix that, and maybe that hyperpigmentation is one reason that you shouldn't kind of undertreat those patients. But in addition to that, I think it's really interesting that if we can get out of this understanding the mechanisms behind PIH better, that'll help us on so many fronts, including cosmetic ones. Like, wouldn't it be nice if you were able to align colorimetry to development of PIH, and then that could guide you in the depth of the peel you use, the laser settings you use. That could be really cool.
Well, I think everything you brought up shows that the future is very bright when it comes to treating skin of color, not only those patients with plaque psoriasis, but other inflammatory skin diseases, or like you said, cosmetics as well. I know the emphasis across the board, whether we're going to conferences, we're listening to webinars, podcasts like this one, there's been a lot of emphasis on those special considerations in skin of color. Do you think we still have work to do? Is this the tip of the iceberg?
No, we have a lot of work to do, but with studies like Visible, thankfully, we're starting to make that work happen. It's interesting because for years we've quoted studies in the skin of color literature as gospel, but you look at the actual studies, the ends are less than 10 patients. All these studies that we look at quoting ceramide content, sensitivity of skin, they're not necessarily like very large or well-designed studies. So when it comes to a pharmaceutical company actually putting the money and resources into developing a trial from the ground up in skin of color population, I think this is a good signal to everybody else. Hey, you got to keep up with this. We're headed this way. And it's exciting. We're starting to see other studies coming out with similar kind of designs looking at skin of color population. So the future really is bright.
I couldn't agree with you more. Are there any final thoughts that you have for our listening audience?
When it comes to psoriasis, we have our classic picture of psoriasis that we keep in our mind. And I think it's just important to remember that everybody's affected differently. And it's important to keep in mind the comorbidities. It's important to keep in mind, special sites that affect people more, such as the scalp, for example, which tends to be more symptomatic, tends to involve our skin of color population more. In some studies, over 80% of our skin of color populations can have scalp psoriasis. And that really is the most symptomatic and problematic part of psoriasis for a lot of people. So just, remember what got you here, the love of caring for patients, being kind of clinically detectives, if you will. And hopefully we're going to get more resources out of this that are going to help us. But just be excited about taking care of your patients every day as we are.
I love that. That's the perfect way to kind of bring this session to a close with George. It's always such a pleasure chatting with you. I feel like I'm always learning something new, and those little tidbits and pearls are always valuable. Thank you for being here and sharing your expertise and insights with our audience, and I look forward to seeing you soon. Thank you all for tuning in.
Stay tuned for our next episode of Psoriasis and Skin of Color Unplugged, titled Treatment and Clinical Study of Psoriasis in Patients with Skin of Color, featuring expert dermatologists Andrew Alexis and Jennifer Sung.